any implications for those who are diagnosed with an eating disorder or found to have one or may have one in terms of their use of GLP-1 or um, anything you might see in with your patients, either Susan or Dr. Harrison?
So I can take that first if that's okay. So I think this is a really, really important question. And when I talk about managing patients effectively and safely, I think screening patients for eating disorders before they go on these medications is critically important and something that is completely overlooked in most primary care practices and certainly in subspecialty practices that are handing out these medications. And I would say likely many of these online mills, if you will, are very unlikely to do it. And I can tell you that nearly 25% of people that come to see us in our program have disordered eating that needs to be addressed. And when I say we're monitoring these patients very, very carefully, number one, we know if they have eating disorders before we put them on the medication. We likely will not put them on the medication until we have appropriately addressed the eating disorder and brought them to a place where we think it is safe to go on this medicine. And then we will be monitoring them very, very closely. We also have a dietitian, a behavioral health counselor, eating disorder specialist. So we do all of that and then think that we can make very great progress with these medications. But I should also say that I have great concern about the cosmetic use of this medication and what we see on award shows. I actually had a patient the other day who said that her 9-year-old was watching an award show and said, you know, Mommy, how do I look like that? And I'm not going to say the name. How do I get to look like that? And so I think whereas we had a great little moment where we were recognizing the disease of obesity and treating it, now, unfortunately, rather than looking at this from a health perspective, we are getting back to looking at this as a body image and thinness perspective, and people are getting smaller and smaller. And I'm afraid this has increased the stigma of patients who are not responding to these medications, can't afford these medications, and we're sending out some really scary signals.
Dr. Harrison, your reactions, thoughts?
I feel like I'm Dr. Wolver's Amen corner this morning
You're
because
allowed.
amen. Um,
I'm thinking
oh,
I want to hang out with you. We need to get
I know,
together.
right? Like, slack me your phone number. But so incredibly important. One, the under recognition of eating disorders. So the general concept of eating disorder is anorexia, extremely thin, where we definitely have eating disorders with normal BMI, even above normal BMI. And so you can't just only use your BMI as the only indicator to ping you to think about disordered eating. Dr. Wolver said 25% we should be screening everybody. And then totally on the body image, especially with our younger adolescent girls, but also our adolescent boys as well, and into those early 20s. This is excruciatingly important to be screening for disordered eating before it reaches diagnostic threshold for eating disorder. And then lastly, from a health equity perspective, the one thing that is a definitely right now negative downfall signal that we're seeing with the GLP-1s is the socioeconomic disparity. So
Yes.
those folks who have access to the
Yes.
GLP-1s who are getting early benefits for weight loss, the cardiometabolic benefits, the immunomodulatory benefits, individuals in lower socioeconomic communities or individuals with different insurance products, I should say populations, not individuals, we are already seeing a widening. So even that statistic I said about the obesity growth rate slowing down does not apply to all populations. And so we need to really be putting our eye on the health equity ball for this one.
Mhm. Is there a role for screening? My dad used to always tell me, and he was in sports medicine at a university, so on the sidelines, but he also worked in PT clinic, and he would struggle. He would tell me he'd struggle with patients. He couldn't get their knee issue resolved, and he thought it was himself, and it would materialize actually into someone that had an eating disorder. It took him 2 months to figure it out. that led me to pretty much, I'm like, I bang the drum on that with any physical therapy clinic and others to say, why aren't you training your staff on at least trying to recognize, mental health, addiction, perhaps eating disorders, and bake that into your protocols and your practice, and don't just sort of just take your visits and treat the musculoskeletal issue, maybe something else. So as we talk about GLP-1s are obviously now like embedded now in this broad, not just it's TikTok into clinical care, that the spectrum of how they're discussed and debated is widening. Is there an important role, what would you worry about in terms of other screening or, and creating a screen around use of that and thinking about where they refer?
There's universal screening, which means you just screen everybody. There's selective screening, which means you screen populations that may be at higher risk for eating disorder. We know that athletes are at higher risk for eating disorder. I
Yeah.
would have to look for a physical therapy clinic. Like if you look at the prevalence of eating disorder in a general physical therapy clinic, I don't know the answer to that. It's probably not universal screening for the entire physical therapy clinic, but it should be selective screening for individuals that meet certain criteria, age, athletics, dancers, entertainment industry, right? Like there are certain risk factors that could come up with it makes sense to screen for eating disorder when these factors are met.
And if I could just add on to that, training of providers and lots of these other ancillary providers as well, because if you ask primary care providers, most of them or many of them will still think that a patient with an eating disorder is a 15-year-old thin white woman. And actually, eating disorders come in every sex, every shape, every size, every age. So that is a big step in the right direction. And we're seeing more and more of this sort of atypical anorexia that Dr. Harrison mentioned in people who are on these medications, who have lost a bunch of weight and are terrified to have weight regain or maybe lose access to their medication and then start to develop very disordered eating around the fear of weight regain. So it's a fascinating field. The more you look into it, the more you realize you do not know about it. But it cannot be patients should providers and physicians should not be treating obesity without having some basic understanding of disordered eating and how to appropriately screen.